And welcome back to our last little lecture of this first module. This one will be a little bit quicker than the first two that we did. We're just talking about some of those complications that are very common to occur in the first trimester of OB. We mentioned these briefly on the previous PowerPoint, but these are all something that you are going to be experienced with in the clinical setting, even if you don't work in an OB office. As you've seen at this point, a lot of our outpatient facilities and a lot of our hospitals do get first trimester patients in the ultrasound department, and these are first trimester complications. So we are going to be seeing these, and we do need to be aware of what these are and what that treatment process is for these patients and what our responsibility is. So the first complication that is extremely common is a subchorionic hemorrhage or hematoma. The two terms are kind of interchangeable with each other. This is a result from the implantation process. So like we kind of learned about with that first trimester development, when that blastocyst starts to burrow into the decidua, it's going to result in a little bit of bleeding, right? Because if you think about it, like you are burrowing into a very vascular type of structure, and you're going to kind of be shedding some of those cells. So that blood needs to accumulate somewhere. So this is a very common sign of implantation, a very common first trimester ultrasound finding. This is going to be located between the myometrium tissue of the uterus and the gestational sac itself. If we have a really, really big subchorionic hemorrhage or hematoma, this is not normal. This is worrisome. And if it continues to bleed and it continues to get larger and larger, it can result in loss of that pregnancy. So it can result in a spontaneous abortion. Clinically, this is going to be the most common cause of bleeding in the first trimester. This is, again, very common. We see a lot of women come in with first trimester bleeding. It's extremely nerve-wracking. This is usually going to be the culprit. We also do see cramping in these patients as well. So what does that look like on ultrasound? We are going to be able to tell how old that blood collection is depending on its echogenicity. So if it's old blood, if it has been there for a few weeks, if it's starting to resolve, it's going to become anechoic. So it's going to become a little bit blacker on our screen. If we're still seeing some echoes, echogenicity, some debris in that collection, it's going to be newer blood that has started to accumulate. And then we also can sometimes see what we call a subchorionic lucency. So we can see that chorion a little bit better and that amnion a little bit better when we really probably shouldn't be seeing that at that time. So if we look at this bottom, actually let's start with our top picture here. My little drawing bar thing is like right where I want to go. So I'm probably going to cut it off a little bit. But see how this hematoma is kind of minding its own business over there, right? It's between the gestational sac and the myometrium of the uterus. When we look at the second picture, we start to see, oh, what's this echogenic membrane? That's my amnion, right? And then we have our chorion. So that is where it's going to accumulate. It's going to accumulate in that chorionic cavity of that early pregnancy. And then if we look at this bottom picture, it kind of doesn't look like those first two at all. It almost looks like a little separation between the chorion and the myometrium. So it depends on the severity. It depends on how old it is. Again, the only thing that we really care about is the size of it. We don't care if we have that little trace lucency along our chorion. We don't really care if it's anechoic or echogenic. We really care about how big it is and how long it's going to continue to be there for. So if we happen to see this, regardless of what it looks like, we are going to be doing a follow-up on that patient to see if it's going to be resolved naturally. Now, usually the uterus is just going to absorb all of that blood over time, so it's going to disappear, but sometimes they can stick around for the rest of the pregnancy. Of course, as that pregnancy grows and develops and gets bigger and bigger, we're not going to be able to evaluate it later on in that second and third trimester because it's going to be so small in comparison to that baby and all of that amniotic fluid that's happening. Next is ectopic. So unfortunately, this is common as well, and it is very emergent regardless of where this ectopic pregnancy is occurring. This is a controversial type of situation going on in the social world right now. Ectopics are not up for debate in terms of saving a woman's life. This is deadly. Regardless of where it's going to occur. You can't have a baby developing anywhere other than the organ that it is intended to develop in, because you run the risk of rupturing and internal bleeding and losing both lives. So very controversial, very unfortunate. There really is no other treatment other than just removing that pregnancy if that mom wants to continue to live. So very unfortunate thing that is important for us to be able to do our job properly to get that diagnosis. So this is when we have implantation of a conceptus outside of that endometrial cavity where it belongs. Some common locations that we can see these ectopics are uterine. You're probably thinking, well, isn't that where it should be? But we're talking about uterine tissue. So if it implants in the myometrium, it shouldn't be there, right? Because the myometrium of the uterus is not the endometrium or the endometrial cavity. It's not where it belongs. Also, we can have a heterotopic pregnancy, which is considered a twin pregnancy, where one pregnancy is developing where it should in the endometrial cavity, but the other pregnancy is an ectopic. So that intrauterine pregnancy will be okay, but we need to go in and surgically remove that ectopic wherever it may be located. We also can see ectopics located in the cervix or the cervical canal. We can see them located in the ovary. And then most commonly, we're going to see ectopics in the fallopian tube. So somewhere along that fallopian tube pathway, we can get these conceptus that start to implant there. So basically they started implanting too early, right? Because we want to wait until it travels into the uterus and starts to implant into the decidua. So it just started to implant too early when it is resulting in the fallopian tube. Now it is important to also know surgically where in the fallopian tube it's located. So we can have it along anywhere from the adnexal aspect to the isthmus aspect of the fallopian tube, but most fallopian tube ectopics are going to occur in the ampullary region. And then the other thing that you need to be aware of is that the most life-threatening location of a fallopian tube ectopic is going to be the interstitial region. And this is because this is where all of our maternal blood vessels are traveling through that area. So we have all of our big arteries and veins, even some of our segmental arteries and veins, our uterine arteries and veins are all located in that region next to the interstitial portion of our fallopian tubes. So we need to make sure that we don't have a pregnancy developing there, because again, as that baby grows and grows and grows, it's going to put pressure on that vascularity and it could potentially rupture those vessels, causing massive internal bleeding on that patient. We also can see ectopics located anywhere in the abdominal or pelvic cavity as well. So anywhere in the adnexas, even all the way up into the flanks. We have a picture on our next 2 slides from now about an abdominal ectopic. So we will talk about that a little bit more. There are a lot of clinical and sonographic indications of what an ectopic is going to look like. The ultrasound indications, or rather the ultrasound findings, are all going to vary depending on where that ectopic is actually located. So it's a lot of hide and seek with our job trying to find these. But as we know, if our patient comes to us and they have, a high HCG level, they should be like at least 10 weeks pregnant, and we're not seeing an intrauterine gestation sac, we need to know that it's probably occurring somewhere else. So we got to go fishing for it. Some symptoms of an ectopic, some clinical symptoms are going to be a positive HCG, of course, a clinical triad. This is going to be what we call an adnexal mass, or a palpable mass in the adnexa, cramping and bleeding. Now, as we already know, there are other complications that can go with cramping and bleeding, right? So cramping and bleeding is not like a one-size-fits-all clinical symptom. We're also going to have cervical tenderness, and then of course if this ectopic is compressing vessels or is rupturing, then the patient can go into shock. So they're going to have extremely low blood pressure, hypotension, they're going to have blood accumulating in their peritoneum, and this is going to be life-threatening. This is highly emergent. Treatment for an ectopic, like we said, is always to remove that pregnancy. So depending on how far along that gestational age is, we may need to do it under surgical guidance, and also depending on where it's located. but there are some options for pharmaceutical treatment, so you can take a medication to evacuate that pregnancy if it's located anywhere in the uterus or the cervical canal. So if we're talking about an ectopic that's in the fallopian tube, in the adnexa, in the ovary, in the abdomen, we're not using medication to evacuate that pregnancy. We're going in surgically to remove that. So who's going to be most likely to suffer from an ectopic? Any patient with a history of endometriosis. And if you're thinking, well, why? What does that mean? Endometriosis is when we have endometrial cells located outside of our endometrial cavity, right? We know that the endometrium is where we want the decidualization process to occur. That's where we want the blastocyst to implant. So if we have endometrial cells near our ovary, right, or all the way up in our fallopian tube, those endometrial cells are going to start to also undergo that decidualization process. And when that zygote and that morula and that blastocyst develop, it's going to find those converted, quick pause. Okay, sorry about that. So the endometriosis cells, the endometrial cells, if they're in that ovary or they're in that fallopian tube and they're undergoing that decidualization process, then that blastocyst that's getting ready to implant is going to find those cells and say, oh, okay, like this is where I need to set up my shelter, right? So it's not the location that it should be because you're having those cells somewhere where they shouldn't be. Also, PID, this is pelvic inflammatory disease. This is a really unfortunate type of STD. This is something that we scan a lot of in the GYN world, and it can, depending on how severe it is or how long we let that go untreated, it can cause scarring in the fallopian tube. It can kind of cause like decreased motility in the fallopian tube. So of course, if your tube isn't working properly, it's not going to allow that blastocyst to get into the uterus and the endometrial cavity the way that it should. Also, any sort of fallopian tube or uterine deformities, so those abnormal uterine shapes, tubal scarring for whatever reason, if you've had a previous tubal ligation or you had it removed, or you've had endometriosis and they went in and they removed it from your tube, you're going to have some scarring. Also, any patient who has an IUD, that IUD may be sitting in that endometrial cavity. So it's like, nope, your pregnancy can't come here, right? You can't stay Like, you don't have to go home, but you can't stay here type of thing. So that's what your IUD is saying. It's saying like, nope, I'm in the endometrial cavity right now. Like, you can't sit with us. You can go implant yourself somewhere else. Also, any patient who has a history of IVF, as we know, that is a very highly scientific based process of creating and monitoring pregnancy for patients who struggle to do so naturally. So of course we're using a lot of different types of medications and a lot of different procedures. So of course anything can happen with those scenarios. Also, if you've had a history of an ectopic previously, or you've had a history of a C-section. Now when you have a C-section, we're cutting your lower uterine segment. So we're cutting the portion of your uterus that's going to be in communication with your cervix. Now you have a big surgical scar in that region of your organ. That tissue in that area where you were cut is sensitive. It's not as strong as it should be. You have scarring in that region. So the pregnancy may see that area as like a path of least resistance. So it says, ooh, like it looks like, you know, pretty open over there. It's like an eligible spot for me. Like, I don't really have to do much work to set myself up. So let me go and implant myself in that C-section scar of that lower uterine segment. Here we have some ultrasound pictures of what these ectopics look like depending on where they're located. Another pause. Sorry guys, quite the little interruption. I just said that we were going to have a very quick lecture today, but I do apologize. So we have some different types of ectopics here depending on where they're located. So this top picture is going to be what we call our cervical. Our top left picture is going to be our cervical pregnancy. So as you can see, our uterus coming up here. Again, my little drawing box like sits right where I don't want it to. Here we have our endometrial cavity. It looks like there's like a little bit of fluid going on up in that region. So it's responding, but the gestational sac and the embryo are developing in that cervix. So unfortunately, this also is considered an ectopic. Top right picture, we see a little bit of our uterus here. We see some ovarian tissue here because we have some follicles, right? This is our entire ovary. And then this is the ectopic, right? So we don't want to see that. Now, ovarian ectopics can very easily be confused with hemorrhagic cysts, with degenerating corpus luteal cysts, with follicular cysts. So we need to make sure that, hey, yeah, we checked that patient's clinical history. They have HCG levels. They don't have an intrauterine gestation or an intrauterine pregnancy. And you may even see a fetal pole in there with a heartbeat. So I have seen one of those. I have scanned one of those. It's very unfortunate. But that is exactly exactly what it would look like. This bottom left picture, this is going to be a fallopian tube location. We have our transverse uterus here, we have our ovary here, and right in between the two, smack dab in that fallopian tube, we have our ectopic there. Now this bottom right picture, this is the abdominal pregnancy. So if we're looking at this, this is a CT scan, and this is like a 20-week-old, like 18-week-old baby developing in her liver. So this patient actually did not survive, and neither did the baby, unfortunately. So these pregnancies can really happen anywhere. Okay, so heterotopic pregnancies, like we mentioned earlier, this is when we have an IUP and an ectopic happening at the same time. Clinically, this is going to result in an abnormal level of HCG. So it's going to be like abnormally high, but maybe not as high as it necessarily should be in terms of that doubling per time period. Patients who are undergoing IVF are going to be the most likely candidates of having this. A lot of times with IVF treatment, we implant more than one embryo, and that can be the cause of this multiple gestation pregnancy. One sticks where it should, and the other implants where it shouldn't. Clinically, the patient will have a palpable adnexal mass, pelvic pain and bleeding. They could have a fever and leukocytosis. And again, depending on where that ectopic pregnancy is located, we could have some intraperitoneal hemorrhaging as well. Here is what that is going to look like. So we have in both of these examples our IUP happening in the endometrial cavity as they should. This bottom picture, it's a little bit harder to evaluate that endometrial cavity because it looks like the anterior myometrium of the uterus is really thick and prominent. So it looks like that IUP could potentially also be a uterine ectopic, but we can't 100% prove that. The main thing is that this pregnancy should not be happening in that lower uterine segment near that cervix. Same thing with that top picture. This is happening right outside of our uterus. I would most likely say that that is happening in our fallopian tube or in our adnexa as well. Next, we have anembryonic gestation. So moving away from our ectopic pregnancies, this is also known as a blighted ovum. So both terms are used interchangeably, but the medical term is anembryonic gestation. The patient term is called blighted ovum. This is when we see a gestational sac where it should be, but that baby has not developed at all. We're going to see variable HCG levels. Clinically, the patient is going to have a really small uterine size for what their dates should be. They're also going to have brown vaginal spotting, and their cervix is going to be closed. So unfortunately with that, like your gestational sac grew and developed, maybe even your yolk sac grew and developed, but we don't have an embryo that developed. So this is kind of what we term like an empty sac. And this is when we have an empty amnion too. So if you look at this top picture, pretty straightforward, nothing going on in that gestational sac. We know that mean sac diameter would be well over 10 millimeters, probably over 18 millimeters, and we're still not seeing an embryo. If we look at our bottom picture, we can even see this amnion where we should be seeing a little babe, and we don't. So I'm very unfortunate for these patients. Next, we have embryonic oligohydramnios. Oligohydramnios is a condition that we are going to talk about frequently in this semester. Same thing with polyhydramnios. We're talking about the amount of amniotic fluid that is happening in that pregnancy. So oligohydramnios is not enough fluid, and polyhydramnios is too much fluid. So when we're talking about oligohydramnios, we really are only seeing that in the first trimester. That's usually going to result in a failure to thrive type of pregnancy because there's not enough amniotic fluid to support and protect that baby. This is going to be caused by something happening in the maternal system. So any sort of maternal disorder can result in not enough fluid being produced. Clinically, the patient is not going to feel any fetal movements, and again, their uterus is not going to be growing as big as quickly as it should be. So Collaborate doesn't like me, and it literally cut out exactly what the picture wants to show. So basically, we are seeing a small gestational sac in comparison to the crown rump length of the fetal pole. We are going to be doing serial ultrasounds to monitor the growth because sometimes this can correct itself. Sometimes all of a sudden the amniotic fluid could start accumulating and everything is fine. But typically this is something that is going to be worrisome. So I will make sure that your PowerPoint that's posted has the correct picture. But basically, if that's our gestational sac, this is going to be like the fetal pole. So that baby is growing as it should, but now the gestational sac isn't because there's not enough amniotic fluid to expand everything. Next, we have gestational trophoblastic neoplasia. So this is known as GTD. There are different types of conditions that come from this. So this is kind of like the overarching category of disease. This is when that trophoblastic tissue from early pregnancy, remember we said the blastocyst is made up of the inner cell mass and the trophoblastic tissue. This is when we have something abnormal occurring in that really early stage. So this is occurring during or shortly after the blastocyst is implanting. This can actually occur months or years after you've had any type of pregnancy. So it's very scary. We see women in their 40s who haven't had a kid in the last 20 years coming in with GTD. And that's because they've had these residual trophoblastic cells just kind of like laying dormant in their body. And now all of a sudden they're just going to start like rapidly proliferating. And it's going to give them all these very similar pregnancy symptoms. So the patients are going to have that nausea, that vomiting, hyperemesis gravidarum. This is that severe vomiting from pregnancy. We're going to have really high levels of HCG, even though the patient is not pregnant. So you're probably like, Emma, you're contradicting yourself because only HCG in the body when there's a pregnancy. Well, there was a pregnancy in these patients maybe 10 years ago, but for some reason, those trophoblastic cells and that trophoblastic tissue hung around, right? It proliferated, and now it's kind of saying like, hey, I feel like growing right now. So they're not truly pregnant in the general sense of this disease. Now we're going to get into one of the variations of this disease where it's a little bit questionable if they're pregnant. These patients will have that high HCG level even though they are not actually pregnant. They are going to have hyperemesis gravidarum because of that severe increase in hormones, and they are going to have rapid enlargement of their uterus like they would if they were pregnant. You know what this kind of reminds me of? It's kind of weird. If you've ever seen the M. Night Shyamalan movie Old, where they're on that beach and everything is just like, this is a spoiler if you haven't seen it and you want to. But when they're on that beach and everything is sped up in terms of their aging process, and that girl, that like young teenage girl gets pregnant and is pregnant only for like 3 minutes and then gives birth, like that's what I imagine these GTD uteruses looking like. Like that's how rapidly enlarged I feel like these uteruses get, even on a patient who's not technically pregnant. Sorry, that was kind of like a strange segue. So now we're going to talk about some variations of gestational trophoblastic disease. You can have what is called a hydatidform mole. And even from that, so a hydatidform mole or a molar pregnancy is a type of GTD. And then we even have further subcategories of a molar pregnancy. We can have a partial molar pregnancy or we can have a complete molar pregnancy. The clinical symptoms for both of these are going to be very similar. They're going to be very similar to severe pregnancy symptoms. So hyperemesis gravidarum, enlargement of that uterus, HCG levels. It's going to have an effect on our thyroid. Pregnancy in general has an effect on our thyroids, so that's usually not something that people tell you, but it's an unfortunate reality. Also, high blood pressure, so preeclampsia, very, very kind of bizarre situation. Now, depending on if you're partial or complete, it all goes to what happened in that fertilization process of early pregnancy. So if you have a partial molar pregnancy, it's when you ovulated a normal egg, but 2 sperms fertilized it. So basically like the sperm were fighting and the egg was like, listen, I give up. I can't deal with this masculinity. I'm like, I don't want either of you. So the fetus is going to develop, right? That inner cell mass of the blastocyst will develop, but the trophoblastic cells of that blastocyst are going to be abnormal. The primitive trophoblastic cells are basically like, listen, I don't know who I came from. Like, I don't know what you want me to do. I don't know what to do. So those cells are going to be abnormal, but the inner cell mass is going to continue to turn into an embryo and therefore a fetus. So we see a developing baby. So we're technically pregnant, but we also have this other really abnormal mass going on in that pregnancy. And we'll show some pictures of that on our next slide. When you have a complete molar pregnancy, so this is not a true pregnancy. This does not result in a baby at all. This is when we see this 10, 15, 20 years down the road. This is when you have had an abnormal egg. So you ovulated an egg that maybe shouldn't have been ovulated. It's fertilized by a normal sperm. So now the role is reversed. So the baby is not going to develop, that inner cell mass is not going to develop, but the trophoblastic cells will. So basically, when you're looking at gestational trophoblastic disease, was the egg abnormal or were the sperm abnormal? If the egg was abnormal, then the baby's not going to develop. But if the sperm was abnormal, then the trophoblastic cells are not going to develop. So either way, if you have an abnormal egg or an abnormal occurrence of sperm, your blastocyst is never going to end up being normal, right? Because one of the two components is always going to end up not developing the way that it should. So complete abnormal egg fertilized by one normal sperm, baby does not grow, but trophoblastic cells continue to. This is going to be the most common form of GTD. This is super common. This is going to occur in women under 20 and over 40. So kind of like a opposite end of the spectrum sort of thing. Now, these women who haven't been pregnant in 5 years, 10 years, 15 years, this is what they're going to experience. Complete. So here we have our ultrasound appearances of both a partial and a complete. When we're talking about partial, this means that the baby is developing, right? But we also have this abnormal proliferation of the trophoblastic cells or the trophoblastic tissue. So if we look at our top image, we have a baby in both of these. But then we're like, okay, what is this piece of Swiss cheese doing? That is the molar pregnancy. So this is going to obviously result in complications for that baby. I wish I had statistics on the success of these babies making it to term, but the reality is that these babies that do end up making it to term, they're going to be abnormally small, so they're going to have growth restrictions, and they're usually going to have some other sort of chromosomal abnormality, because if you think about why that happened, you had a normal egg, but it was fertilized by two sperms. So that was an abnormal event that happened. So when the genetics of this baby were developing and the chromosomes of this baby were developing, of course something wasn't going to match up. So it ends up in babies with triploidy as well, and that is usually going to be incompatible with life. We're going to learn about triploidy and some of the anomalies that go with that later on in the semester. The complete molar pregnancy, we're not seeing a baby, and we're just getting an entire uterus that looks like a bunch of grapes and Swiss cheese. So I've scanned one complete molar pregnancy before. She hadn't had a baby in, I believe it was like 12 years. For some reason, she had those leftover trophoblastic cells from a pregnancy that happened years ago, and they happened to just proliferate at that time. So when we're talking about the overarching gestational trophoblastic disease, any form of a pregnancy, so any type of event where you had trophoblastic cells in your body can lay dormant until years down the road. Now, you can get a complete molar pregnancy after you've had that pregnancy 10 years ago. You're usually not, I say usually because nothing surprises me, but you're like 99.9% not going to get a partial molar pregnancy unless you are actively trying, right? So you're not going to have this baby develop out of nowhere, but you can have a complete molar pregnancy develop out of nowhere. So it's a very weird type of condition. It's kind of scary when you guys first learn about it, because you're like, oh my God, like, why can I get pregnant 10 years down the road without doing anything? Like, that shouldn't happen. But this is, overall GTD is not super common, but a complete molar pregnancy is common in terms of that GTD. So we're going to see a lot of these variations. Next, we have choriocarcinoma. This is another type of GTD, but don't worry, like, you're not gonna end up with a baby from this. This is a little bit more worrisome in terms of malignancy. So this is when we still have those trophoblastic cells, and a tumor is starting to develop because of that. It is going to be a highly vascular tumor, so it's going to result in potential bleeding, hemorrhage, and tissue death. It is very rare, so it can only occur from a molar pregnancy, right? So you can't have, so say you have a baby, everything is fine. You don't have any trophoblastic cells left in your body. None of them are laying dormant. You don't need to worry about choriocarcinoma. If you have a baby and you somehow have these trophoblastic cells left over hanging out in your body, you could get a molar pregnancy down the road. If you get a molar pregnancy, if you get a complete molar pregnancy, you have the risk of getting a choriocarcinoma from that molar pregnancy. So think about what the odds have to be in terms of you getting this type of cancer. Clinically, we're going to have an enlarged uterus. We're going to see HCG levels in a patient who is not pregnant. So this is what the ultrasound appearance is going to be, less suspicious than a molar pregnancy, right? So it's not going to be as obvious as what that molar pregnancy was. It's going to be a little bit more discreet. It looks a little bit more like a solid tumor. And we just want to make sure that we're not confusing that with a fibroid, because fibroids are not going to take on this complex sort of appearance. We're not going to see fluid and solid components in a fibroid usually. So we're also not going to see highly vascular supply to a fibroid usually. So again, we want to make sure we're getting a good patient clinical history on these patients, and that we are looking for any sort of discrete abnormality. Hopefully I didn't scare you guys too much.